Hey folks, Rob Howdo here with my partner Tyler with Full Spectrum Training Systems, and Tyler's been getting some knee pain. And we were going to assess and treat this. We figured, well, screw it, we'll do a video and show you some basic process. So, Tyler's background includes a lot of soccer, Aussie rules football, and lately he's been doing a lot more movement exploration style training. So things like parkour, things like ninja warrior training, a lot more explosive power, acceleration, deceleration control. So right there, we got to make sure we really rule out things like ligament damage, maybe meniscal damage. I've already kind of had a look, ruled those out, but I'm going to take you through a quick and dirty on just checking the major structures of the knee. And then we're going to show you what actually is going on and some quick and dirty ways we can treat that. So, Tyler, I'm going to start stressing some of the ligaments. I want you to let me know if anything causes you pain, okay?
Okay, that's super fun.
So first things first, and let's assume I've done a bilateral on the other side, but we already know what's going on here. So I'm going to push on the outside of this knee and pull on the inside of this ankle. I'm going to check and see if I get a valgus deformity, which I don't. You got any pain there? What a shock. Okay, next, I can pull while I push. So I'm going to pull on the inside of the femur and actually block it down and push the outside of the fibula and try to look for a varus deformity. Any pain? No. So we've basically ruled out the medial and lateral collateral ligaments. Now, for the MCL, we can actually get into more torsion and valgus. Anything? And that's going to be, like right here is kind of a gold standard stress there. For the anterior cruciate ligament, I'm going to sit on Tyler's foot, block out the foot, and pull an anterior drawer test. Don't let me pull. Or sorry, relax. Okay? I'm going to pull forward, and what I'm looking for is any degree of translation of the tibial plateau on the femoral condyles. And as you can see on there, there's basically nothing. I can try a Lockman's test, block out the femur with the web of my hand, hook under the medial tibial plateau, and I'm going to let my thumb rest on the joint line. The nice thing about this is it takes the hamstring muscles out of the equation. So we don't get the same ability for the nervous system to block our test. We get a more true positive if there's an issue. And nothing out of the ordinary there. A little bit of movement, which is what I'd expect of the knee. Any pain there? Yes, no? Okay, so I've kind of safely ruled out the major ligaments. Last one is maybe a sag sign for the PCL. And I mean, I don't see anything when it's under normal weight. I can push on it. There's no major deformity there. There's no translation of the tibial plateau posteriorly on the femoral condyles. We're pretty safe. Any pain with that one? Okay. Ligaments, ruled out. Meniscus. I can go through, hold the knee, and what I want to do is kind of trap the heel, put the ball of the foot on my forearm, and I can turn his leg into external rotation, and I can now start challenging the meniscus. So I'm axially loading, I'm compressing, and I'm essentially sweeping as I push the knee into valgus to challenge that lateral meniscus and try to see if I can challenge those meniscal horns. So I'm pushing them into internal rotation and into external rotation and see if anything gives me any grief. Any pain? No catching, no popping. Meniscus, check. Lateral meniscus. Medial meniscus, same thing. I pull the leg towards myself, turn out at this foot, and I'm just doing the same. I'm axially loading, I'm compressing the femur, pushing in, and I'm sweeping through that meniscus. Any pain there?
Right where your elbow is.
Sorry, that's what we're getting to in a bit. Sorry about that. So I'll be a little softer with my arm. Is that less cranky?
Yeah.
Pretend I know what I'm doing, folks. And I'm checking that posterior to anterior medial meniscus, and then into internal rotation, same thing. Anything in any of there? No pain, no clunking, no catching, anything? And I'm not detecting anything either. So let's say we're comfortably safe in assuming no ligamentous, no meniscal. And so that fairly safely rules out the new types of training, the redirectional training, as having caused acute injury in there. There's no mechanism that would indicate a fracture, so I'm not worried about a tibial plateau fracture, a femoral condyle fracture, or a patellar fracture. Those are nasty. There's nothing that would indicate massive cartilage degeneration, especially at his age, his general health, and the characteristic, but he's getting knee pain right in through here. Okay, which I probably should have covered from the beginning of the video. Now, if I palpate, I'm going to check in through the pes anserine. Anything in here as I swipe along that? I don't want to dig in too deeply because this is tender on a lot of people, but I do want to generally go over it, feel for any signs of bursitis, feel for anything. Like if you can palpate that bursa, it's probably swollen. If you can feel a bulge there, it's swollen. So nothing I can feel there. I can go out to Gertie's tubercle for the IT band, same thing here. Anything there? And as I'm generally kind of centralizing into that painful spot, I'm trying to avoid causing false positives, so I'm really getting closer in. Lateral IT band, anything there? Anything at that lateral patellar attachment of the IT band? No? Okay. Now, patella. Superior and inferior translation. I'm just feeling for smoothness of glide. I'm feeling for comfort. Any discomfort there? I'm feeling for crepitus. Medial to lateral translation. Good range of motion. Little bit of crepitus in there. A little bit of grinding in there. Not exactly abnormal given that he's a soccer player. Any pain with that? Okay. Probably kind of feels good actually. I can look at internal and external or medial lateral rotation. And everything feels pretty smooth. Nothing feels really overly worrisome. If I feel a lot of laxity, that could be a problem. If I have a lot of translation up or down, superior, inferior, that can be a problem. But otherwise, no signs of patella alta or baja, no signs of previous dislocation. So why does it hurt? Let's look at it massage therapy style. Let's look at the muscles. Check the hamstrings at their insertion. Any pain in there? Now at the posterior tibial plateau on the medial side, and at the lateral side, and with the fibular head. Nothing bothering you? Good. Let's go up. It's more of the muscle bellies, the hammies. Anything there? Okay. Let's check for insertion of the groin muscles. We already got the pes anserine. We already got gracilis included there. So, if I move the knee a little bit, I can find right there, I'm on the joint line with my finger. Move superiorly to that, and that'll be the medial femoral condyle under my finger right here. Okay, I'm kind of tracing that out. And if I fall superiorly off of there, how's that feeling? And Tyler is making a face like he just stuck his finger in an electrical socket. We consider that a positive sign. What am I on? I'm on the adductor tubercle. I'm right on that little tubercle just north, just superior to the medial supracondylar ridge. Holy crap, took me a while to remember that. And this adductor tubercle here is the attachment for adductor magnus. So I can go adductor portion of adductor magnus, and that feels a little cranky. I can go hamstring portion. Holy crap, right? What does adductor magnus do? Adductor magnus acts as the connector when we're moving from extensor dominance to adductor dominance. Its real key job is that transition from one movement to another. And transition from one movement to another is where we tend to be the most vulnerable. When we're changing direction, when we're eccentrically to concentrically loading a muscle, it's most likely to tear. When we're changing direction from one group of muscle dominance to another, that small period in between that they're transitioning, the more smooth that is, the less pain. Tyler is a pretty lower limb dominant athlete, but he's challenging things at a larger range of motion now. Ninja Warrior training has a much greater degree of abduction and hip flexion to adduction and hip extension. So actually crossing the midline and kicking through to change direction than anything else he's ever done. A lot of step up, step down, a lot of step up and crossover, a lot of dive and Kong over things. And so he's challenging those transitional movements in a way he probably never has. He's muscle sore. It's basically a sign of overtraining. Now, what can we do for this? We can cheat. We can do a positional release. Adductor magnus is really, really good for that. So I can find that acutely tender spot, on it right there, and I can bend the knee a little bit, and I can move the leg over. How's that now?
Better.
How much better? Is there any pain?
No, not as much.
Okay, there's no pain or there's not as much
Not
pain?
as much.
I want no pain. I want no pain. So I can now turn in more. Any pain there?
No.
Okay. And we can hold this for 2 excruciatingly boring minutes, which we're going to film through because I'll just blah, blah, blah at you. So when I'm treating like this, I mean, the goal isn't to try to change the tissue structure, obviously. We aren't getting in there and breaking up scar tissue, especially not with a treatment like this. What I'm essentially doing is letting the nervous system ping the region. Ping means essentially to tag it back and forth, to detect more often. So I'm taking a painful, tender spot, putting it in a position where the pain drops off, and letting the nervous system kind of scan back and forth and say, oh, actually, you know what? I don't think that's a risk nearly as much as I thought it was. And if I then take him back to a neutral position, the pain's dropped off, we can start work on gradually opening that up, gradually adding more eccentric load to those structures. We can work on sort of gradually adding more dynamic eccentric load, more change per unit time, more stretch response, more stretch demand, more load. And we can then work into exercise-based rehab. So right now we drop the amount of warning. We drop the amount of question mark. And once it's a more known entity, once the brain says, oh yeah, okay, that thing's fine, we start using it again. And to use that, we go into things like Cossack squats, side lunges, PNF patterns, any of the above, or anything else that kind of challenges in there. Okay, back to neutral. How's the pain?
Not as bad.
Okay, and you're not making that face like you just smelled a dead raccoon. I'm glad with that.
Yeah.
Okay, what's the pain like right now compared to before? So if we went on that pain scale, where are you right now?
It's uncomfortable. It's not
Okay.
like stinging or
Okay.
overly painful. It's just
Let's go for the hamstring division. What's that one like? No? Okay. What's that like in there?
probably like a 5 out of 10, 5 or 6 out of 10.
Okay. And if I go back to that attachment point, how are you here?
Yeah, 4. Not as bad. Like nowhere near as bad.
Okay. So let's do the same thing. Tender there?
Yep.
Okay. How's that?
Good.
More info. Is it good or is there still some tenderness?
Still a little bit of tenderness.
Okay. And if I turn inwards, what's that like?
I can just feel your finger.
So no tenderness left?
No tenderness. No.
Okay. Another 2 boring minutes. So once again, we're letting the region ping. We're letting the nervous system kind of detect and say, oh yeah, nothing wrong here. Now, you'll know that this isn't necessarily origin insertion specific to adductor magnus. It's close to it. I mean, we're coming from medial to the ischial tuberosity down to the adductor tubercle, and this is largely shortening it. Internal rotation seems to add a little bit of fine tuning to that for Tyler. Bear in mind, our origin insertion info, don't go by that. Don't go by just the textbook. Everyone's a little bit different. So I'll take the idea of a muscle attachment origin insertion point, and I'll use that as a gentle framework, or as a gross framework, and from there I'll kind of gently fine tune and see what works for each person. I don't know necessarily why. I'm fine with not knowing why for now. What I know is that individual, that patient says, yeah, that seems to feel better. That seems to decrease my pain. And given that that's a major goal today, I'm fine with that for now. And then from there, we want to empower our patient to be able to explore that on their own. So if I teach Tyler some exercises to explore this, some open kinetic chain work, so there's less risk of taking it off again, some closed kinetic chain mobility work, closed kinetic chain resistance work, and then closed kinetic chain dynamic resistance work. So open kinetic chain, legs up in the air, he's making circles, he's doing abduction, adduction, clamshell style stuff, seeing how that feels. Close connect chain, things like 90-90s, try to get that hip rotation, and some 90-90 kickouts, try to get that abduction challenged and see how that feels. Close connect chain resistance, some weight bearing, some deep squat kickouts, some Cossack squats or side lunges, really challenge that. And then add some acceleration, deceleration to that. So crossover drills, karaoke drills, deep side lunge kick-ups, deep side lunge step-ups and explode and turn out, or explode and pivot out, and see how that feels. And we can gradually stagger step up from the most simple and the easiest to the most difficult and the theoretically most physically challenging, and you can map out what you can safely do and build on it. All we need to do is make sure that you know to trust and listen to your body. If it's sore, don't force it. Go relatively simple on yourself. Any pain now?
The more you pull, yeah.
More what?
The more you pull, yeah.
Okay. And here?
No.
Here?
No.
Here? Okay. Original tender point, how's that?
No.
Okay. So that was a really simple, straight out of school tool from our toolbox. And it's a really effective one. If we isolate the structure, if we rule out the big stuff first, we reassure our patient, yeah, you didn't seem to do anything mechanically wrong that I can detect. Then we go into the associated structures, the stabilizing structures. Knees are really dependent on hip and ankle. This is a case of knee pain being caused from the hip to the knee, not just the knee. And then from there, we pick whatever tool in our toolbox suits our capability, our patient's needs. And in this case, it was strain, counter strain for me. Challenge the tender point, shorten the structures, allow them to adjust to it, and re-challenge the tender point. And that's it. So today we can go into some more remedial exercise-based stuff, more exercise-based rehab, and move on from there. Thanks very much.